All right, it is noon on my clock, and so we're gonna get going here. I'm Dusty. We got Dr. Koehler on the screen with me. I'll introduce him here really soon. Before we do, I'm gonna give you a little context of who I am and why we're doing a webinar like this, really quickly, less than 2 minutes, and I'm gonna hand it over to Dr. Koehler. If you didn't hear, if you just joined with us, we do take some live Q&A. We love live Q&A, and so if you have questions about anything we're talking about today, feel free to use the chat within here and we'll be able to see those and we'll grab those and answer those most likely at the end of the presentation. All right. So today's webinar is how to be more profitable by treating work injuries. And so Co-Work Health we are focused on making the business side and the relationship management side, the communication, the payment side really easy and modern for OccHealth, urgent care mixed groups out there. So that's what our role is. Dr. Koehler and his group with OccDocOne is really about supporting, and obviously he's going to speak to this, but supporting the clinical side and making sure your team feels confident and is able to do that. So Co-Work Health, we started off with how do we make you get paid faster and more easy? That's our number one goal, is like we want you to get paid for the OccHealth services. EMRs typically aren't built for this very well. They're typically focused on patient billing, insurance billing, not on OccHealth billing, which we all know is a little bit different. And so typically we take clinics from, getting paid within like 75 days on average to getting paid in less than 30 days. We see that and we hear that story all the time. That's where we started, and we feel like we have a really good solution in place for that. But since then, we have expanded upon that. So Co-Work Health is now a broad platform to really manage your entire client relationship with OccHealth. So from authorizations, your customers can go into Co-Work Health and digitally authorize services for their employees rather than have to send in paperwork. This results in, fewer phone calls, less paperwork, less scanning, all that good stuff. You can then send the paperwork post-visit. We call them results, right? But it could be anything that you need to send securely through the same platform. So they can find those, you get fewer questions, fewer resend requests, things like that. Again, the key part then is you're then sending the invoices in the same place they're authorizing services, and they're getting the results. And so they're more likely to pay for those invoices without questions. They can pay for those online for the platform. And if they don't pay, we have automated follow-up so that you get paid without having to pick up the phone 1,000 times and make them pay. The thing that ties it all together then is that messaging piece. So if they do have questions or anything, they can do that right through the platform. It gives them contextual items to those questions. So if there's a question about an invoice, that invoice is attached to that item right there for you, so your team can respond more quickly for faster resolution. And then finally, task management allows you to organize all those to-dos to make sure you don't nothing falls through the cracks, right? So if you need to correct an invoice, resend a result or anything like that, you can just assign yourself or assign a different team member a task. So really it's a platform to organize and take some of that stress away from spreadsheets and sticky notes and all that stuff and put it in one platform for you and your OccHealth clients. And so that's Co-Work Health. We do have CRM coming soon as well. So for the sales part of OccHealth, that would all be within the same platform. That's what we're currently working on, and that will come. So that's the context of why is Co-Work Health doing this webinar with Dr. Koehler. Again, we are not affiliated. So OccDocOne, Co-Work Health, we're not affiliated, other than we have a similar passion in wanting to make OccHealth more profitable for these centers and make it easier for them to manage. We both see an opportunity there for clinics. And so Dr. Koehler will speak to that. But let me introduce him really quick and I'm going to hand it over. So Dr. Koehler is board certified in occupational medicine. He's been doing this for a long time. He's been in the space for 40 plus years. He founded his own group, Physicians Immediate Care. If you've heard of them, they were 56 clinics when they sold out. He sold out in 2022. He pioneered the hybrid model for urgent care in OccMed. He was one of the founding board members of the Urgent Care Association, and now he started a tech company that helps clinics deliver work comp and OccHealth services as well. That is only a little bit of what he's done, but he's done a lot. I'm excited for you to hear from him. He's super passionate, and he'll tell you exactly what you should be doing. So Dr. Koehler, take it away.
Okay, thanks, Dusty. Appreciate that. So I'm going to tell you everything I can tell you. Okay, so it's going to be a major data dump. And so take notes, write your questions down, put them in the chat. Happy to address those toward the end. So I want to start out with a little bit about my own story, context, that I came out of ER residency. I knew how to do, obviously, trauma and such like that. we started our first center as a little hobby deal, from our ER group. Like, this would be kind of cool to do. There was a spec building in Rockford, Illinois, which is north central Illinois near Wisconsin. Spec building was put up, a Class D location, a bad look. I mean, nice building, but for urgent care, you got your A, B, C, D sites. If nowadays, if you have a C site, you'll go broke. Okay, you know what I mean? Guaranteed. B is even like bad, but everyone's looking for those A sites. There's lots of saturation, but you got to have the visibility to get the urgent care. So anyway, I had a lousy site, and we're going broke, after about a little over a year. It's not really working out. And then I got tipped off about OccMed. And so I thought, okay, well, let's check it out, see what I can do. I started meeting with some trucking companies to do DOT physicals, and it worked. And so I figured out, okay, good, I can drive revenue with the telephone. Okay, no internet, no cell phones, but sticky notes and a telephone. I made appointments. I went out. I started recruiting business. I built the hybrid model, meaning I had to do it for survival. So it's not like I had a brilliant idea. Okay, I didn't. I had a survival instinct, because with a wife and 3 kids, failure was not an option, and I didn't want to leave town. And so I had to make it work, because our ER contract kind of blew up because of political stuff, but some of them left. I stayed. I started running the clinics, and I figured out the hybrid model of urgent care and OccMed. So what I mean by that is my survival depended on treating injuries. Okay, because OccMed is it's an address destination. It's not visual images like with urgent care, where they have to literally see your site 1,000 times to know you're there. Okay, and remember you when there's an earache and a sore throat. Now with OccMed, you call the company, set up an appointment, go present your program, and they decide to use you or not. That's for a different talk, which I'm happy to come back and do that sometime if you'd like, on sales, OccMed sales. But so I had to do this. Okay, and then I had to train my providers to do the injuries. And so we had a trauma room, x-ray, like you folks have. And so I was able to make it happen because the revenue coming in for these work injuries was so much higher. I mean, so much higher that it really got my attention. I realized, what, these are pretty cool, these accounts, because it's like an annuity. You get a new account, your revenue goes up a little bit, another one. And if you do a good job, you're literally ratcheting your way up the revenue stair step, so to speak, to the point where we actually had 40 million plus of annual OccMed revenue, 150 million in total annual revenue when we sold. So this is not like small potatoes here with these injuries. So here I am watching this industry evolve over time. In the last 10 years, I have seen, and it's nobody's fault. Clearly, nobody's fault. I'm not trying to throw stones at anybody here, okay? But I'm trying to tell the truth too. The truth is that we didn't have doctors anymore. We started our first PA in 1995, and so we worked our way up gradually. I remember they said, do you have any, where's the doctor? You know what I mean? And nowadays it's like there aren't any, okay? But the evolution is nurse practitioners, PAs, God bless them. We love them. Fantastic. But you can't be trained to treat injuries at a robust level with 1 year of rotations where you have got to do internal medicine, family practice, dermatology, whatever. Are you getting ER or not? You know what I mean? And not all of them have gotten any ER. Not all of them have even sewn a single laceration, all their training. And so this is what's been happening, where the experience level has been falling with the progression towards nearly 100% APP staffing for providers in urgent care centers. And with that has been what's called acuity degradation, where we're not doing the serious stuff. It gets referred. Why? Because if the APP says, I'm quote unquote not comfortable with this, they refer it. And unless there is a system to train them and get them comfortable, then this is what's happening. It's like a stair step down. And the CPT codes at the large EHR companies has proven this to be true, that the CPT levels per visit are falling, or per hour of service, whatever you want to call it, falling precipitously. And with that revenue and with that profitability. So right now, our industry is greatly challenged on the profitability side. There's some large groups that are doing kind of slow movement liquidation. They're not announcing it. They're just doing it. They're selling chunks of their clinics out. They're selling them because they're realizing they can't be profitable in their current model. So I'm trying to help. So is Dusty here, to try to get the word out for ways that you can you can sustain yourself through this period where we're evolving to where I believe illness only urgent care centers are going to go out. They're going to go out. Okay. So, there's a lot of quote unquote, agnostic groups like, okay, big health system. Oh, you're not profitable. We're going to close you. It's like, there's no conversation about what can we do to be profitable? What can we do to sustain ourselves? Like adding occupational medicine to the mix, doing more injury care or other things that aren't germane to this talk, but there's other things that can be done. But so I'm saying that the nut needs to be cracked. And so for you, if you are in control of your practice or highly influential, maybe the owner of your urgent care practice. I remember a friend of mine told me, who's also an urgent care operator, name is Cameron Perkins, great guy, said, John, you need to work on your business, not in your business. So there was a time when I needed to kind of exit a lot of my floor time, because I was working a lot of floor time, and start working on your business. So I'm encouraging all of you, you need to have think time that you simply think about your business. I remember I told my leadership team once, I said, everybody, every problem we face, we can solve with money until you run out of it. Okay? Seriously, the easy way to solve your problems right now is spend money. And I'm saying to you, until you run out of it. So don't take the easy street, think that you need to go borrow more money, spend more money, answer every problem with money. Sure, there's investments to make, and I'm going to be talking about that. But I'm saying that you got to put think time into your business where you can concentrate and you're not getting all kinds of phone calls and people bother you seeing patients, and you need to get think about your business. So the things that I talk about today, if you face challenges or impediments to implementing it, please take think time to work on it and figure it out, because you're smart. I know you're smart. You can figure this out. Okay. So you can solve these problems and you can be focused. And if you have an agenda, not only you need focus, but your key leaders need focus. So if you have a key agenda, let's say we're going to do workers' comp injuries more in our clinics, whatever you are right now, we're going to increase it. You need to think about who's going to be on point, who's going to drive the changes and the necessary forward motion, and who's going to be accountable for that. And will you free up their time? Because platitudes and big statements, nothing. Whoopee. Whoopee dang. Okay, anybody can make a big statement. We're going to do OccMed, new program, and then walk away. I guarantee you nothing is going to happen unless you are able to resource that project with a focused leader on it. Emphasis, focus. Because I've seen this movie over and over and over again, that everyone's solving hair on fire problems today. Nobody can get anything done fundamentally and get good forward motion on a fundamental basis. I remember I hired a chief operating officer. It was a great luxury for me to hire a chief operating officer, which I did. And I told this chief operating officer, I'm just giving you an example here. I said, okay, you're starting in August. I'm going to bonus you $10,000 in January. You're not to do any of your chief operating officer work until this project is done. And this project is, I want you to create something called Target Tracker, where you set up an online system, like a spreadsheet system, so every leader in our company can go in there and see the timeline on their responsibilities to open a new clinic. So get this, for decades, I never had a single meeting to open a clinic, but I made her do that. And she did it great, and she had it done, and she got her $10,000 bonus. And we've used the tool. We used the tool ever since. And I never had to have a meeting about starting a new clinic. Why? Because they all could go to that tool and use it. So I solved that by thinking about it and then resourcing it with a focused individual. What I paid her to be on staff as chief operating officer, and then the $10,000 bonus, was chicken feed compared to what it did for our company. So making that emphasis. Okay, how to be profitable in injuries? That's one of it. Okay, you got to resource it and got to focus on it to make it happen. Okay, let's talk about the revenue side, because it's revenue and cost, right? Profits. Okay, what do you got left? Okay, so you got to have the top line revenue, right? You got to have meat to work with. That's your revenue. And so E&M codes, you got to get the right E&M code. So whatever your EHR is, if you're stuck with 99203 and 99213 for the predominance of your E&M codes on your workers' comp injury cases, you need to look at that. You need to converse with your EHR folks. You need to know your EHR. You need to know how the codes are generated, Okay. There's different ways EHRs generate codes, things like, reviewing a differential diagnosis helps to support the decision making for a level 4 code. That's something you have to think about and how you're going to fix that or work with the mechanism and mechanics of your EHR to comply with CMS guidelines to get a reasonable mix of level 4 codes. Okay, I'd say on first visits, you need to have hopefully 50% O4s, rechecks, maybe 40% 1-4s, something like that. It's studyable. You can get into it. So I'm saying you need to look at your E&M code so you're getting the right higher level codes, acceptable levels of codes, not, practicing robust medical care. You deserve to be paid for what you do. Okay. The next are the procedures. Okay. So there's probably, 60 plus relevant CPT codes for procedures that you can do in your clinic that you should be doing to properly monetize the patients that are coming in. That was one of my things is I thought, hey, we got the box here within our 4 walls. We should be able to do everything as much as we can possibly do without relying on sending it out to other places. And one of that is to do the procedures. So catastrophically, there's urgent cares now in the country that are literally triaging in their waiting room lacerations off to the ER. It's happening right now. I know that because some groups have tested it. They've called their own clinic, faking they're a patient coming in. I got this laceration on my finger. What should I do? They say, oh, go to the ER. Okay, happening right now. That's ridiculously inappropriate, and it will undermine your value proposition to your community. And they will figure this out over time, and they will say, well, you know what? We'll go to you for earaches and sore throats, but we're going to go to ortho urgent care, your competitor, for anything ortho. We're going to go to the ER for blood if it's bleeding. We're going to go to ophthalmology for an eye injury, and pretty much you're losing your position. And you don't know you're losing it, by the way. They don't call you up and say, oh, hey, I just thought I'd tell you, you referred me out the other day, so I won't be coming to you for that anymore. Just wanted to let you know. They don't tell you. They just don't come back. And you're bouncing along 20 visits, 30 visits a day, and making a little bit of progress, and you're blaming it on maybe competition or something else, when really it's your own clinicians that are referring too much of it out. I'm not saying it's their fault, because if they're uncomfortable and not trained adequately, that's on you, okay, and on your medical leadership. It's important to have medical leadership that's inspirational in nature, that will inspire your medical providers to practice at the highest level of their license. Why are we like, let's figure out how we can practice at the lowest. Okay, what's the lowest level? Oh, that's triage. Why are we practicing on injuries at a triage level? An RN can do that. Seriously. And they are doing it. We got telephonic nurse triage for work comp. And you know what? If urgent care doesn't deliver, you know what they do? They just triage them to multi-specialty groups, triage them to ortho urgent cares, triage them to the ER. And I've heard that too from employers, that their nurse triage system just sends them to the ER. So they're not doing their job either. So anyway, if you do what I'm talking about correctly, and potentially OccDocOne later, we'll talk about that. But I can tell you, you can grow your business to beat the band, because your competition is low and falling fast. I can tell you that right now, because I know the employers. I have many employers that use my site. I know them. I've worked with them, and I know what they're thinking about too. But anyway, on the procedures, okay, really, really important. Okay, you need to know what the applicable CPT codes for dislocation reductions, eye injury, foreign body removement, corneal rust debridement, laceration repairs, fracture care, all those CPT codes. And then you need to analyze all your providers around those CPT codes. And you can get that out of your EHR. Put in your provider and query for the CPT codes, and get a stratified list of all of their CPT codes and then do a comparative analysis of all your providers. Okay. This is working on your business, not in your business. So to work on your business, you literally should know your providers like their fingerprint. You know what I mean? You should know their practice patterns incredibly well. What are they treating? What are they referring? I mean, and that's in their CPT code data. It's easily queryable. This is so mission critical to your financial profitability. I just can't tell you, because if you have a provider that's practicing injury triage, not injury treatment, it's costing you incredible amounts of money, and it's hurting your reputation in the community with the soccer moms and the employers. So you need to know that. And if you have you'll have others that are rock stars on procedures. They should be compensated accordingly. I'll be talking about that a little bit later. But so they need to do these things. And for example, just give you one example, because you might say, and this is toxic. I'm telling you, this is toxic. There's thinking, especially in a really large group with like non-clinicians leading, like private equity sponsored groups, nothing against them. I'm just saying that when you have leadership where they're have the authority and the decision, they're non-clinicians. The way they think, oh my goodness, the way they think is throughput. They think throughput. So then if you say to them, hey, you know what, let's ditch lacerations because they take so long. We can see 3 urgent care cases in the time it takes to sew one cut. Let's not bother with that anymore. They go, you're making a really good point. Yeah, from a profitability standpoint, we could probably, let's not do that anymore. Honest to Pete, it's happening. Not to mention dislocations, fracture care, eye injuries. So here we have a kind of a culture. I don't want to call it laziness. It's close to it though, where the providers aren't comfortable. They just don't want to do it. And they convince these non-clinical decision makers. And pretty much, again, they're down to the level of a Walgreens center. Being an urgent care, you have this expensive freestanding facility functioning almost like a little cracker box in a Walgreens, triaging all these injuries, doing the sore throats, the earaches, great. And then this is your finances. You're not getting the A&M code. You're not getting the x-ray fee. You're not getting the procedure code. So it's really important that these procedures are done, and you need to do whatever it takes to get inspirational clinical leadership that's skilled to do these procedures, to do workshops, to train or provide video trainings, see one, do one, teach one, to help them come along on these procedures. And you screen them in the pre-employment phase too. Have you actually ever sewed a laceration? Yes or no? If they say no, Katie barred the door. You better figure that out. And I know there's desperation to keep clinics open, but if you're 5-clinic network and this is going really badly, I mean, it might be better to close one of them, move the patients to the other 4 until you can staff up with the right staff. Speaking of x-ray too. Okay, so you need radiology. Oh my goodness, this is a problem. So they're gold right now, gold. Get this, I had a group in New York State that has an ad out for rad techs at $80 an hour and can't get anybody. This is catastrophic. So figure that one out. So whether it's, you do the non-radiology tech positioning with the provider pushing the button, other MA certification to do x-rays, whatever your state law is, you must be absolutely compliant with the state law, but go after it right now and beef up your rad tech presence. If you have to share one regionally between 3 clinics, then fine. You got to do something. You got to keep those x-rays, because you cannot do workers' comp without x-ray, because they need x-ray at the time of service. If you don't, delay it out, send them somewhere else. That's really a mess. The better thing to do is have the rad tech on call to come in and do it. So they're on call for 3 clinics. They go between the 3 clinics to do the x-ray. And on a sidebar too is you might not be able to multitask the rad techs anymore. They might be x-ray only from now on. Okay. So you have to work out your staffing for that. Okay. So the x-ray revenue is very important. $75, $85, whatever you need to be able To get that, you bill out under workers' compensation, fee for service. Case rates don't apply to workers' comp. Don't ever, ever, ever sign a case rate for workers' comp. And this actually happened where a group was credentialed and they had a contract with, I believe it was Blue Cross Blue Shield, and for urgent care. And somehow they started paying case rate on worker comp. And they tried to do that little flipperoo in there and pay for work comp under that contract. No, 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 no. Never, never, ever, never, never do that. OccMed work comp is fee for service. Okay. So anyway, you got to get the procedures, the x-ray, the durable medical equipment, DME, otherwise known as splints and supports. Okay. I like to use the word supports. Splints should only be for fractures and things like that, because you want to use it as a support so that it's not OSHA recordable. As a support, it's not immobilizing the joint. So your wrist supports, your tennis elbow straps, your boots, your hinge knee supports, your back supports, all of that, you must have that in your clinic, and you must dispense it to maximize profitability and properly monetize workers' comp. You have to do that. It's just, I can't just tell. I mean, if your E&M code, you might be getting $150 for your E&M code. We would net $140 on every back support that we would collect $140 on every back support. We would pay 40, collect 140. Our net was like $100 on every back support. That is serious revenue. We made millions of dollars on DME. So don't overlook that. Don't think you can't do it. Don't think it's not monetizable. You have to crack the nut. If any of you reach out to me, I'm happy to refer you to my DME guy, my DME supplier expert, Sean Blackmore with TLC DME. Been my guy for 30 plus years, does a great job. If you want a referral to him to talk to him, he'll talk to you. No obligation. But you got to monetize DME, and your providers and your staff needs to know how to put it on. I can't tell you how many clinics I've been in, literally doing consulting and stuff, and like it's there, and I go, hey, you use it good. Oh, we don't use it that much. Why not? Because no one here knows how to put it on. And that's from a doctor telling me that to my face in the clinic. We don't know how to put it on. We don't do it. I mean, it's the lackadaisical attitude is toxic to your profitability. Okay, pre-packed pharma, OTC medication, Tylenol, naproxen, Advil, ibuprofen 200. If you can dispense that, it's a profit center. We pay $2, we collect 15 to 20. That pays your AMAs, your MAs right there, right then and there. Because if you're giving roughly two bottles of OTC pre-packed pharma to every first workers' comp visit, or most of them, sprains, strains, contusions, 2 bottles, it's non-recordable. It's a one-stop shop. It helps support the one-stop shop model. The patients love it, the clients love it, and it's profitable for you. Come on. This whole thing that I'm talking about with work comp is beneficial for the patient. The one-stop is beneficial to the patient. They don't have to go somewhere and pay for stuff. The companies love one-stop. They don't want to have to pay for receipts of these little things off at pharmacies and DME companies and all that kind of mess. They want them back to work. They don't want them 45 minutes waiting for some pharmacy situation. So you can I have a pre-packed pharma guy too, that Destry Sutzer with Proficient RX. I can refer you to him if you ping me on that. So you got to do this. You got to monetize this. This is like, it works like this. It's so perfect. Okay. Okay. So let's move on to provider bonuses. So providers say, no, you're asking me to do more, but are you paying me more? So depending on your culture that exists with your providers in your clinic right now, I've seen that. Others would say, fantastic. I've always wanted to do injury management, orthopedics. This is great. I want to do injections. I want to do fracture care. This is fantastic. So I've recruited PAs that call me up and say exactly that. Hey, I heard you guys do a lot of stuff. I'm tired of being told what I can't do with this health system. I want to join you, Dr. Koehler. I said, okay, great. Come on board. And then I get these rock star PAs. So how do you do that now? Well, I don't know where your culture is right now, but you need to try to work towards a rock and roll culture where these providers want to rock and roll. They high five each other with a new clinic revenue record or volume record each day, where they did, hey, I did my first shoulder dislocation reduction. This is fantastic. And I've had that. I've actually, over the telephone, I've proctored a shoulder reduction for the first time with a provider because it's incredibly simple. Okay, incredibly simple. It sounds horrible, sounds big, but it's not. It's simple to do. If it doesn't work, what have you lost? You refer them then, but at least you can try. Okay, put the lidocaine right in the glenoid. Work. It's a pretty easy procedure. Traction, external rotation, boom, it's in. But anyway, so if you have someone in your organization who gets an MBA, they get a raise, right? Somebody goes from MA to RN, they get a raise, right? Why is that? Because they have additional training and do more things. Well, why not do that for your providers? If they are able to show that their ratio of CPT codes is going up and up and up, and you set a CPT threshold for your bonus program, give them a monthly bonus, and you can merge it with other bonus systems programs you have. But I'm telling you, I had PAs making an extra $3,000 per month, and I loved it. They won, I won, companies won, patients won, everybody wins when your providers are doing procedures, CPT codes. I just can't say it enough, okay? And you bonus them, and I was bonusing them on their procedures. You could use RVUs, you could use the CPT codes, you can do whatever you want. And I know you can figure it out. The data's available. Give it some good think time, because you need to align your provider's income with the profitability of your clinic. There's even groups out there, I know this for a fact, that they actually bonus on gross or net collected revenue. They bonus on net collected revenue. I'm not going to get into the Stark referral stuff, the legal stuff. It's terrible what some of these big groups, they get so legally tangled up, they can't get anything accomplished, and they don't make any money, on and on and on. But you can crack that nut. I know you can, because I did. All right. Never had a problem with it. So do the bonus. Okay. Let's talk about the cost side here, so we have enough time to answer questions and such. But on the cost side, okay, you do need to invest in the right equipment. You have to have an Opti spud. It's a spatula. Okay. It's got a blunt end on it. You just, to lift off the foreign body off the corneal surface, it's what, $10? You got to have an eye treatment tray, one of those plastic things, put all the stuff in it, carry it around the clinic. Okay. Put on the side of it the name. This is the eye tray. Here's what's in it, so your folks can keep it stocked. You got the fluorescein. You got the head mounted magnification. You got to have the tray. You got to have the I&D tray. You got to have the ENT tray for nasal or ear foreign bodies. You got to have the laceration tray for suturing, etc. You got to have Morgan lens to irrigate the cornea for a corneal chemical exposure, etc., etc. So you've got to invest in the procedure trays, the right equipment, and you got to invest in the DME. The DME cabinet that you have, closet where you put the DME, you have to stock it. But the prices for the reimbursement, it's a no-brainer to do that. There's even stock and bill programs. My guy Sean Blackmore can help you with that. You won't even have to pay to stock your clinic. Okay, he's unbelievable in how he helps the clinics that I work with out there. He does a great job. On your staffing, I want to talk about staffing a little bit. Obviously, on the cost side, overstaffing is a problem. What I'm recommending, and this is kind of paradigm disruptive, try to evolve towards no receptionists, okay? Because you have 4 classes of staff. If you have receptionists, rad techs, MAs, and providers, that's 4 classes. That's 4 classes of training, 4 classes of everything, employment agreements, all that kind of stuff. If you can remove one of them, you're down to 3 classes of employees. And I know this is tumultuous potentially, but you can retrain some of the front desk to be MAs, okay? You can repurpose them into billing or other areas, EPS processing, for the drug screens and records managements and stuff like that. But simplify. So the MAs go to the front and they register the patient, take them back, and the other MA rotates to the front. Rad tech, if you have them, can rotate like that. So you only have 3 groups to cross-train. Can make it simple. And by all means, and I've got ways to simplify your paperwork as well on OccDocOne. I have a print shop with universal exam form and all kinds of good stuff on that. But simplify on the staffing level, okay? You need to invest in certifications. You have to have breath alcohol testing certification, DOT certification. All your providers have to be DOT certified to do DOT. You can't do workers' comp if you don't do DOT physicals. You got to get that done. If you're going to do asbestos physical, silica, asbestos regulatory exam clearances, you need to have a NIOSH certified MA to do the spirometry. Those are the two exams where you have to have NIOSH certified spirometry. Otherwise, you can do respirator clearances without NIOSH certifications. There are certain certifications. So some of this costs money, but again, think it through. The revenue is off the charts. I mean, when you get a global fee for $1,000, $1,000 global fee to put a boot on a simple little avulsion fracture of a distal fibula, it's $1,000 cash money. Like, why would you refer that to ortho? It's happening all over. In fact, ortho urgent cares were created by us in the urgent care industry because we sent all this dinky stuff to their offices, gumming up their offices, these orthopedic surgeons with non-surgical ortho. They had no choice. They had to hire their own nurse practitioners and PAs and put a moniker up, urgent care, ortho urgent care right here. And that's where they all go. So the PA nurse practitioner takes your case and takes care of it. And they have MRI right there, X-ray, PT, podiatry, ortho, physiatry, PT, all this stuff. And they grind away on that. And it costs your employer clients so much more money to treat a work injury because it got referred to this, mothership ortho place. But surgical cases, absolutely. Needs a pin, screws, surgery absolutely should go to ortho. But why not treat within the scope of your license, which means you can do fracture care? Absolutely. I have 65 fracture guidelines in OccDocOne, along with 385 total to help guide a clinical decision support to make this work. Okay, let's go to questions now. Okay, all right. I see. Will you share this recording?
Yeah, I'll go to the top here for Dr. Koehler, and I'll throw them at you. But towards the top, if you scroll up, Stephen Presley asked, his hi, Dr. Koehler, is there a recommended procedures list that could be provided? I have all of our current data CPT codes, but I want to make sure we are not missing specific procedural billable opportunity.
Okay, great question. Okay, so I have the list in OccDocOne under CPT. Okay, so here's what I'll do for anybody on this call who wants. Yeah, okay. This is the, if you did www.OccDocOne.com, you will get to this site right here. You're looking straight at it, upper right hand corner. Schedule a demo. Click on that, and I will show you OccDocOne in a demo. And then I will let you have a temporary access to OccDocOne. Even if you decide not to subscribe to OccDocOne, I'll give you enough time to copy it. Okay, to copy the CPT codes list. It's there, so no problem. Okay, so I'll show you the site. I'll show you the CPT codes. I'll let you have time to literally use the site for a week, and you can get it off there.
Awesome. Hunter's asking, what percentage should OccMed/work comp be of urgent care, the blended model? What percent?
Great question. What should it be? Okay, well, I will say what it realistically can be. No brainer. Even if you're in you say we're in a residential area, there's not much work comp here. Okay, those injured workers are embedded in the nursing homes in the community, restaurants, nursing homes, fast food, muffler shops. There's a zillion employers. The workers' comp is there. I would say at the lowest level, 25%, highest level, 60. We had some clinics where we did a hybrid location. So we are where the industry is, but we're also where there's urgent care, like, a corner place, and so we had upwards of 60% work comp OccMed at some clinics. And so I'd say 20 to 60% is your range. But if you're now at like 5% and you go to 20, that is real money. If you've ever done the metrics on any additional, like 5 visits a day, if you did the metrics on that, if you added 5 visits a day for a year, it's astronomical what that does for your profitability. Because if you're sitting at 25 patients a day and you go to 35, absolutely monumental game changer on your finances.
Yeah. So Dr. Koehler was an operator, and that's, from our perspective, from the tech side, what we've seen is that 20 to 30% are high performers in the blended model. And so you go above that, you're doing really, really well on that side. But the high performers were in that 20 to 30% doing OccMed work comp.
And the workers' comp rechecks are easy visits. So they're easy visits. They're the easiest visit you'll ever see. They're so easy because 90% are getting better. All you got to do is advance them a little bit each time. And then, they're easy. So every shift I worked, I had 20 or 30 rechecks. Every day I worked, I had 20 or 30 rechecks scheduled. And they're the easiest visits all day.
All right, next question. On OccDocOne, 8 of the 9 listed key treatment procedure videos are injections. Has anyone attempted ultrasound-guided injections to increase quality of treatment in billables? And then he adds, we have the rad text available. I'm trying to increase the scope of modality to offset cost and limited x-rays being performed.
Well, that's a multifactorial question. Okay, it's not going to reduce x-rays, I don't think. You really need to check. I'm not an expert on this billing for ultrasound. You're looking for fractures. So on the ultrasound guides, I've never done it because I never needed it. Truth be told, and I'm not saying you can't have ultrasound, but you're kind of like trying to practice calculus when this is algebra, okay? With the ultrasound, because here you got to buy an expensive equipment. You've got to train them all to do it. If you watch my videos, I do the injection in 5 seconds. It's this in the subacromial shoulder. It's a 5. There's nothing in there. You don't need an ultrasound for that. The space is wide. You can't miss it. It's no more technically difficult than a flu shot. It's efficacious, and you bill for it. And yeah, maybe you can bill a little bit more for an ultrasound guided, but I consider it, I hate to say it, but radiology invented it. So physiatry, radiology, they invented it to get more money. And it's not, I can see ultrasound or, CT guidance for epidural injections. I can see that one. I can't see it for shoulders, knees, elbows. No way. It's not necessary. It's borderline inappropriate. No, major in the majors. Don't major in the minors. Don't try. Everything I'm talking about today is majors. Don't get complicated. If you try to do all, you're killing a mosquito with a jackhammer.
This next question might be, we might be the wrong audience for this question as well, but what CPT code do you use for fracture care is the question.
It's on my website. I can show you that. Same thing, same answer as before.
Okay.
There's a lot. Every bone can be fractured. So yeah, there's a ton of them. But I focused on the ones that are more germane to the urgent care space.
So many first injuries turned away. Did you forecast downstream revenue based on ratios of new injury to follow-ups? And did you bring in PT, chiro, etc. in-house?
Okay, that's a lot of questions. Let me focus. Okay, I brought PT in-house years ago because the PT was saying to the injured worker, hey, have you seen an orthopedic yet? Oh my gosh. They were undermining my care. Literally, the physical therapists were undermining my care of the patient. I brought it in-house. I still have it in-house only at the really busy clinics in-house because you have to have the necessary volume to justify a PT unit. If you have a PT, you need to talk to the PT if you're referring it to about how you practice and tell them you don't talk to them. You're not their doctor. If you have any issues related to doctoring, you call me, not talk to the patient about it. Don't ask them questions that undermine my care. Okay, the other one was, what else do we bring in? PT, pain management. Don't bring it in-house. You can do your own. We did our own epidurals for a while. I'm not telling you to do that. You can refer to pain management for the epidurals, but only one at a time. If they get better with one, you don't need 3, okay? So keep control of that. It's in my guidelines on how to do that, in the lumbar guidelines for radiculopathy and those kind of things. What was the other one to bring in-house?
Chiro, PT.
You can do it, but chiro in-house, the employers hate that. They despise chiro, unfortunately. They would view that as you're corrupting your product. If you had chiro in-house, their paradigm is so expensive. They have literally 15 diagnoses on every patient, and they bill all of those. I mean, it's crazy billing. Don't do it. Do not bring chiro. Do not affiliate yourself with chiro. Some of them are fantastic. They're phenomenal, but you can't affiliate with them for workers' comp. You can for urgent care, but not for. Don't ever do it for workers' comp. What was the first question? What was the first question on that? The first part?
First part of that whole question was, do you, so many first injuries turned away, did you forecast downstream revenue based on ratios of new injury to follow-ups?
Okay, so you should average between 3.2 and 3.7 visits per work comp case. So if you have a work comp case, you should average 3.2 to 3.7. If you're too high, you're treating them too long. You're not getting them better. If you're too low, you're just referring too much. I mean, I know a group that has 200 sites that has 1.1 visits per work comp. They're nothing but a triage center. It's terrible, terrible. So 3.2 to 3.7 is the right spot to be in. Forecasting revenue, not hard to do. You could recast, you could look at how many first comp visits did we have last year, last 12 months? How many visits did we have? 1.1, 1.7. What if it was 3.5? What would happen to our revenue multiplying by your mixture of 99213s and 99214s? Because that's a follow-up code. There you go. Bada bing. There's your number.
I'm only seeing one more question here. Do you recommend targeting the insurance carriers, not just the employers?
Okay, you need to be in network with the major, Gallagher Bassett, Liberty Mutual, the big TPAs. So that's a different subject. It's a discount contract for workers' comp. You might have a state-based fee schedule, but there's a discount off that. That's the only thing you need them for, to be in network. You really, if they really like you, then they'll refer the companies to you. Otherwise, you got to go to the companies first, and they'll tell their insurance carrier, we're going to this clinic. That's the primary way to do it. I can tell you, if you do workers' comp correctly, and that's for another talk, how to do it correctly. I'm happy to talk about that. The big four: lost time, unnecessary social recordables, intuitive work restrictions, and first comp phone calls. I just told you a massive trade secret. That's what it is. That's the magic formula for providers. If you do that, the word of mouth will drive your business. The TPAs will send to you their clients because it's getting done poorly elsewhere. If you do it right, but it takes to build that reputation. Your market share will grow. I promise you, it will grow. It grew every place we put a clinic. We had 56 clinics. We were hammering our OccMed growth spontaneously because our reputation was so good.
Awesome. I don't think I missed any questions. If I did, throw it in the chat again really quick. We're about at time anyways. It's perfect timing. I did throw the link. Someone asked for the links to the website. So OccDocOne is in the chat. coworkhealth.io is in the chat. This recording will go out to everybody. So if you need to share it with team members, I know Dr. Koehler runs through things really quick. He's throwing a ton of stuff out there really fast. So that's awesome. But if you need to rewatch it, we'll make sure that recording's out there. Otherwise, it sounds like there's more topics. We might hit at a future date.
I want to mention. We have a little bit of time here.
Go for it.
So on the information transmission issue on profitability, so what Dusty was talking about, and I have no vested interest in CoArc whatsoever, but I don't care what you're doing in your work comp, you better have a portal access. You have to transmit this information efficiently where you put it available to the clients, they go in and get it. You can't be making phone calls all day long and leaving messages and going back and forth. You'll have an army of people in your billing department. No how, no way. You have to report the results of drug tests because they have drug tests with these workers' comp cases. They want the result, 24-hour turnaround on negatives, or rapid testing. You got to post that on a portal so they go in and get it. It's so efficient, saves you lots and lots of money. You can't have a complex back end to your business. And if you want a consultant on back end stuff, I could help you with that. Dusty to help you on how to handle that information flow transmission. It's huge. And Dusty can speak to that maybe in a future conference call with you folks. But you need to look at these tools, his product, perhaps other product, but you got to look at his tool because he's in the belly of the idea of systematic operational efficiency with managing that relationship with these companies. I can tell you they want results, and that will help your business grow, and it will scale your ability to add clients and handle big volumes.
All right, you waited long enough, Dr. Koehler. We got more questions coming in. Greg asked, do you have a portal solution vendor that you recommend?
Hi, Greg. How you doing? Portal solution. Well, Cowork is one of them, right here, cowork.com.
Coworkhealth.io is in the right above that, right above your question, Greg, is the link there.
So go for it. Get on a demo with that. So the best one I know of. Okay, we got a blended model. Encountered the idea that augment visits prevent urgent. Okay, great question from Matthew Taylor. Okay, so yeah, if you fill up your waiting room with fill up with drug tests. Okay, you can't let anybody drop 20 drug tests off at your office. You have to have them either get them in some other room and get them out of your waiting room. But I've seen this happen, where you have this drug testing vendor, well known to you all, okay, who says they'll give you workers' comp and they never do. They just drop off tons of drug tests. You don't make any freaking money on it. So don't ever do commodity drug testing and fill up your waiting room. So that will cause a problem. Okay, so if they think there's a lot of sick people in your waiting room, it never was a problem for us. If you want to do, bifurcate your waiting room and put the OccMed workers' comp in different places, you could have a bay where you bring 2 or 3 people for drug tests, get them out of your waiting room, put them in a bay, take them to the bathroom, stage it that way. Could be a way to. You can't have a full waiting room. People will walk away. You try to keep your waiting room empty. Fill up your rooms. Get your waiting room empty. So then, that's the only way that will prevent urgent care is if you fill them up with useless, non-profitable drug tests in your waiting room. Next question, do you recommend rapid drug screens or tests backed by MRO for legal reasons? Ladies and gentlemen, rapid testing, very easy, quick result. You make as much or more money on it, price it at $40 at least. The results within minutes, post it on your portal, easy peasy. You don't need MRO for legal reasons. You're just doing a rapid test. It's a negative. No one's going to sue you for a negative test, right? So if it comes back non-negative, you have to send it to your lab, whether that's LabCorp, Quest, whatever it might be. Just make sure you make money on it. Okay, please. Employer paid services are 100% pay. Don't ever get in a price war on drug tests. If you do, I'm promising, absolutely promising if you do workers' comp the way I say, okay, I recommend, they will be bending over backwards to come to you for work comp. They will worship the ground you walk on, and they will gladly send you all their EPS cases for full pay, 100%. Yes.
Awesome. All right. You can see Dr. Koehler is full of knowledge. And so we had great questions. We'll post the recording. We might do another one with a different topic at another time, but really appreciate you joining us. Check out OccDocOne.com. Check out coworkhealth.io to make your OccHealth life easier. And hopefully we'll see you next time. Thanks, Dr. Koehler.
Take care, everybody.